Thank you all for joining us. Today is our July. I cannot believe this summer is just flying by. We are in our July KCQBIC forum. And so today we are going to share some updates from the KCQBIC project on improving opioid use disorder outcomes. And so with that, I'm just going to give a little bit of an overview and then a little bit of, I guess I'll give a few logistical updates as well right before I kick things off. So just to share with you all some high level. So the KCQBIC, we have a vision of bringing multiple stakeholders together to improve the quality and value of healthcare. And thank you to all of you as the stakeholders that are also participating with us. And we're supported with support from BioNexus KC, from UMKC, Next Gen Precision Health Institute, and with KU Frontiers Clinical and Translational Science Institute. And what we're really trying to achieve here is really the quadruple aim here in Kansas City. So what we're ultimately trying to do is improve patient outcomes, make better health outcomes, improve the patient experience, reduce costs of care, and also, which has become really important now with COVID, but provide a better provider experience and reduce burnout, which is now kind of the fourth aim of the IHI's triple aim. And so all of this in mind is so that we can improve, quality and value of healthcare and help our patients and populations. And with the QBIC, we're really leaning to building this regional healthcare community in which, we partner with healthcare leaders and providers, the community-based organizations, researchers, payers and purchasers, policymakers, public health, philanthropy, industry, and really, the most important and at the heart of it all really is the patients, right? What we're trying to do is help improve the lives of patients and populations. And so, I love this quote, knowing is not enough, we must apply, and willing is not enough, we must do. And so what we're really trying to do through the QBIC is do that, to be an action-oriented arm where we can really create change in our community for the better. And we have three kind of main strategies that we've been working on where we focus our efforts. The first is that we work on our regional quality improvement projects, of which we're gathered, here today. It sounds like I'm creating a wedding here, but gathered here today to talk about. So we have our two regional quality improvement projects, one of which is the Opioid project, and that's kind of the hospitals in red have been participants in that initiative, as well as our Transitions of Care for Heart Failure project. And we'll be hearing from updates from that group later this year. And in addition to the regional quality improvement projects that we do with implementing and evaluating the success of those, we know that implementing change in care in communities takes a lot of science, right? And implementation and identifying barriers and cultures and trying to overcome them. And so we also have a training program called TIARA currently, our Training and Implementation Actionable Research Approaches. And this is a way to really equip researchers, but also quality improvement personnel or anyone who's working and trying to implement change into practice or communities. And so we have this program and we're also expanding that into other mechanisms and modes and kind of TIARA part 2. So stay tuned. And then our arm that kind of engages with the community and shares a lot of dissemination and brings our community together is this KCQBIC forum, of which we meet monthly. And we're here today for one of them to talk about different healthcare topics in our region and hear from different stakeholders from their perspectives. So we can all kind of learn from one another, share best practices, build new partnerships, and grow together. So those are our activities. And this is our lineup of our KCQBIC forum for this year. And you can see the year is just flying by and we are already here on improving opioid use disorder outcomes updates from the QBIC. Yeah. And next month we'll be hearing on healthcare delivery in a post-COVID world. And with that, that kind of concludes my portion. And so what I'm going to do is I'm going to turn it over to our first presenter, or presenters, I should say, who will providing an overview of the KC EPIC project in terms of visual mapping, process map updates, and development of a logic model. So we'll have Dr. F.A. Liu, who is an associate professor in Division of Pharmacy Practice and Administration at UMKC, along with Dr. Holly Hagel, who's assistant research professor at UMKC in the School of Nursing and Health Studies. So the floor is yours, and thank you. Oh, and the logistical updates, just to tell everyone, please utilize the chat box, enter any questions you have into it. We like to have a engaging conversation in the chat as we move along, and then also share your video if you're happy to. And these are being recorded, so you can also visit these on our website a couple days after. All right, I'm done.
Good afternoon, everybody. I'm Dr. Yifei Liu, an associate professor at UMKC School of Pharmacy. I'm here with my colleague, Dr. Holly Hagel. She's an assistant research professor at UMKC School of Nursing and Health Studies. We will provide an overview of the Kansas City EPIC project. First, I will talk about the visual mapping of the entire EPIC project and the process map updates for the participating hospitals. Next, Dr. Hagel will describe the development of the logic model. This presentation was originally scheduled for 5 minutes in total, but after coordinating with 2 other presenters, Dr. Oates and Dr. Lapierre, it would be fine for me and Dr. Hagel each to talk for 5 minutes. So the presentation would be about 10 minutes in total. This slide displays the visual mapping for the entire EPIC project. I know it is too small to look at the details. Therefore, in the next 2 slides, I'm going to split the mapping into 2 parts, with each part being bigger and easier to view. The first part is about the history and background. At the very beginning, Behavioral Health Network of Greater St. Louis conducted a pilot EPIC project in 2016. The project connected patients from hospital emergency rooms to substance use treatment and recovery supports. 1 year later, Missouri Department of Mental Health received funds from SAMHSA to continue and expand the project. Missouri Department of Mental Health has formed a partnership with Behavioral Health Network of Greater St. Louis and Missouri Hospital Association. The expansion of the EPIC project began in 2018. Other Missouri communities affected by the opioid crisis were identified for the expansion. There are 2 contact persons. One is Ms. Orson, the contact person for the Eastern region. The implementation in the Eastern region is based on the pilot program. The other contact person is Mr. Billings, who is also a speaker today. He is the contact person for the Central, the Southwest, and the Western regions. The EPIC program was launched in 2019 for these 3 regions. And the implementation is to replicate the pilot project. Kansas City EPIC represents the Western region. The second part is about the implementation of Kansas City EPIC. The key player is ComCare. ComCare coordinates with both hospitals and substance use treatment providers. The participating hospitals include Chuma Medical Centers at Hospital Hill, Chuma Medical Centers at Lakewood, North Kansas City Hospital, and Excelsior Springs Hospital. Examples of substance use treatment providers are Swope Health Services and Tri-County Mental Health Services. Both hospitals and substance use treatment providers make patient referrals to peer recovery coaches. In a previous QVIC session, I presented a high-level process map for the overall process of Kansas City EPIC, as well as a detailed process map for each hospital. The boxes of patient referrals and peer recovery coaches on this mapping can be further linked with a high-level map I presented before. quick updates about the process maps. In the detailed process maps for hospitals, the step of referral to recovery coaches was further mapped out. In addition, the concept of referral to recovery supports was defined. The detailed process maps for treatment medical centers, including both locations, and North Kansas City Hospital were finalized and verified by the hospitals. The detailed process map for Excelsior Springs Hospital was completed and needs to be verified by the hospital. Based on the detailed process maps, a high-level map was completed. That is about my part. Now I will hand it over to Dr. Hagel.
Thanks, Dr. Liu. So what we want to take now is share with you some of the implementation models and frameworks that we are applying to the process that Ife just mapped out. So we really want to examine the process and then talk about some logic models that we're in the process of developing. So next slide, please. I just wanted to start, if you've been at a previous QVIC forum, we have shared with you that we've been using the EPIS model, but I wanted to set the stage for the logic model that we're right now developing, which does tie into the implementation model that we have been utilizing throughout our process of exploring the implementation and evaluating, looking at the data and how that interrelates with each other. So the EPIS model developed by Dr. Gregory Ahrens stands for, is an implementation framework that has the 4 discrete phases. It aligns to the implementation process, and I hope that you see that aligning when we talk about some of the internal and outer system contexts. So next slide, please. This is the 4 phases of the EPIS model, and the KC EPIC process was already in place when we started in 2018. So they were already implementing. And so you could say that the QVIC project is in the implementation phase, as well as somewhat into the sustainability phase across this very large scope of this project. Next slide. This is a visualization of the entire 4 phases. You can see it's not linear, and the inner and outer context that I'm going to speak about in a moment. But I wanted to highlight the bridging factors, and that our team in particular, the implementation and data analytics team, is a purveyor in the middle, trying to bridge these factors within this existing context. Next slide. So looking at the EPIS model, we've identified, I'm not going to go through all of these, but some of the outer context that we have to take into consideration from an implementation and evaluation standpoint is the service environment, which is here in Kansas City, Missouri. The funding mechanism is primarily all federal funding, not exclusively, but primarily the majority of it is based on federal funding. But that federal funding is overseen by a leadership team that comes from obviously the federal level, the state level, the Missouri Hospital Association, Mr. Billings, which you'll hear from, all the participating hospitals, and ComCare, and then from ComCare, other behavioral health providers that are engaged. So you can see that the outer context is quite complex. So I'll just stop there. And if you could go to the next slide. When thinking about the inner context, from a leadership perspective, we're looking at all of those participating hospitals that Dr. Liu reviewed, also ComCare as the major input of services, and the other participating behavioral health providers really make up the majority of the inner context. And all of those organizational characteristics interplay into how these services are implemented. And I hope you'll see as we do our snapshot of our preliminary look at the data that all of these intersecting factors really do affect the implementation and uptake and eventually the sustainability of the project. As well as, I'll just, before I go on, the individual characteristics of each of those participating hospitals, right? The nuances of their own workflows. Next slide, please. So I wanted just to give you the actual implementation model that we have been applying. And as a team, we have been encouraged under the senior leadership of Dr. Ann Sales, who's a well-known implementation scientist out of the University of Michigan, to apply a logic model to our work. So next slide. The model that we're currently looking at is developed by Smith and Rafferty. It's the implementation research logic model. And it really is designed to look at any implementation framework or model and to walk it through these various stages. So determinants, and you can even see this one is based on the CFIR model, the example on here, but it also talks about inner and outer settings or contexts, such as the ones I just reviewed. What types of strategies you use, what mechanisms drive those strategies, and what are your expected outcomes. So we are right now as a team in the middle of that, but Dr. Sales has encouraged us to look a little bit deeper at the determinants. So if you could go to the next slide. I'll share with you just our draft model. So we are just now looking at the determinants, and we are thinking of those, if you want to operationalize them, as the barriers and facilitators for how Casey Epic gets implemented at every single one of the hospitals, you know, through the lens of each of the patients. So we are going across this now and defining the mechanisms that of these determinants, and then the strategies of these mechanisms and those expected outcomes. Next slide. So I'm handing the baton. We wanted to give you that framework so that you could look at the data from the lens in which we are going to put those barriers and facilitators together. And we're really relying very heavily on the qualitative data that we are just now beginning the analysis of. And so I'm going to turn it over to our data team, and they're going to walk you through where we are.
Awesome. Thank you so much, Dr. Hagel. And next we'll hear, yes, from the opioid quantitative and qualitative team. We'll hear from Dr. Danielle Olds, who's a research assistant professor at the University of Kansas Medical Center, Dr. Tracy LaPierre, associate professor at the University of Kansas, and Dr. David Jarmowicz, who is an associate professor at the University of Kansas. The floor is yours. And remember, the chat box is there for anyone listening in and having questions or comments.
Hi, everyone. I'm Tracy LaPierre. I'll start us out today and then hand it over to Danielle. And David is on a trip right now and couldn't be with us unless he's snuck in here when I wasn't looking. But so what we're going to do is talk a little bit more about the research perspective, the quantitative and qualitative design and data updates. As Holly was talking about, there is that logic model that we're going to be using and applying. We're going to do with the qualitative analysis, both inductive and deductive coding, but we're in the very preliminary stages of analysis. And I'll talk about a couple of themes related to COVID as part of my presentation. Before that, I wanted to, if I can figure out how to get my slides to advance here. Which one is it? There we go. I just wanted to put us a little bit more in the context of what's going on with opioid use disorder or overdose deaths in general in the nation and specifically in Missouri. And this is from some recently reported data. The provisional drug overdose death counts was just released here earlier this month. And you can see from this trend, am I sharing the right screen? You guys can see this? Okay, good. I see nods. Okay. So based on the available data, you could see here January 2020, and then shortly after that is where we started to get into the pandemic. And you could see how at the national level here, this is looking at the 12-month end. So in the 12 months leading up to this month that the dot is on, how many overdose deaths were there in the United States? And you could see that as we got further and further into the pandemic, that those rates increased. And then when we're looking here specifically at Missouri, you see this increase in the first few months of the pandemic, and then it's kind of leveled off a little bit. The data only does not quite bring us up to 2021 yet. And then this is primarily being driven by overdose related to opioids and synthetic opioids. So they broke it out here based on the type of overdose, and this black line up here is related to opioids. And then the next highest one is the synthetic opioids, excluding methadone. And so you can see there that these are the predominant causes of the drug overdose. And specifically in Missouri here, it follows the similar trend as we see nationally. Okay, so now I'll talk a little bit about the qualitative data analysis and updates. So for the qualitative data, we've been doing in-depth interviews. Some of them have been solo interviews with just one individual, and sometimes we have multiple people from the same organization in the same interview. We've been doing them because all of this data collection has occurred during the pandemic. We've been doing them remotely via Zoom, with sometimes people calling into the Zoom and not video connecting. What we've completed to date is the interviews from our hospital sample, and that includes, dang it, sorry. That includes 12 participants in total that have been involved in our interviews, and they were across three of the participating hospitals. And we've had a number of roles represented in those interviews. We've had physicians, the directors of the emergency department, supervisors, people that supervise the social workers or the nurse practitioners that are working in the emergency department, social workers, and qualified mental health professionals. We've also completed some interviews with ComCare, but I'm not going to talk about those interviews today. And in process this summer, we're going to be completing the peer recovery coach interviews. And after that, we'll move on to do some interviews with clients of the EPIC program and other stakeholders, such as the Missouri Hospital Association representatives, other advisory board representatives, or partners. When we were doing the interviews with the hospital sample, we had an interview guide that we followed. So just as we talk about these themes that emerged, and not all of them we will be able to get into today, I wanted to just say, well, what were the interview questions like? So we asked them for an overview of the process for connecting those with opioid use disorder with needed services. And what did this look like before EPIC, before the EPIC program was implemented? And what is the process now that EPIC has been implemented? We looked a lot at the factors that influence referral to EPIC, asked for their opinion about what's working well, what could be changed or improved, or what would be your wish list of like, how could the program be expanded? We asked about sustainability. We want to understand measures of success, how different stakeholders define success, or what kind of indicators could be used as success for this program. And because, of course, these interviews were taking place during COVID, we wanted to look at specifically what was the impact of COVID on the intervention. So we started out, we're doing some group coding, and there's a lot of logistics in team coding and some stuff with us being at multiple institutions. So this is really a rough preliminary analysis. And I had a number of themes I was going to focus on today, and then I started to get scared with all my quotes, and after reading them that I was going to be way too long. So I just focused on a couple of things that I think are very timely, which are the changes in the opioid presentation and referrals during COVID. Now these are the qualitative data, so they're not necessarily generalizable or capture everything that's going on, but these are definitely the perceptions and experiences of the people that we interviewed. So I think it's been noted before that when the pandemic began, there was some logistics that changed because the hospitals locked down. They didn't want any extraneous persons coming into the hospital. You know, if you were going in as for an appointment, they didn't want the whole family coming along. People were limited in who they could bring with them. And that also included limitations on the peer recovery coaches entering into the hospitals. So the logistics of the referral process changed. And one of the quotes that talks a little bit about that here is that the referrals had been over the phone, and sometimes they have really phones in some of those rooms, and then they tie up one of the nurses' phones. And logistically, it doesn't really work as well. And then that person is not necessarily going to like trust somebody on the phone in the same way that they would trust somebody that they can build a rapport with in person. So one of the emergency department staff here was talking about how the fact that they had to move the connection with the peer recovery coaches to telephone instead of having that warm handoff that's a real signature aspect of this intervention, that created some issues within the emergency department because of were there phones in the rooms, were they tying up other phones that needed to be done for their things, but also they felt that impacted the quality of that handoff and that rapport that was able to be built. And we'll be hearing we'll be asking more about that when we interview the peer recovery coaches themselves as well as the clients. We asked about fluctuations, if they saw any changes in the quantity of opioid presentations. And of course, this wasn't the actual hospital admission data, so it's not that generalizable, but what were their perceptions or what were their thoughts on this? And it really varied by the hospital, and it also varied over time. So they would talk about maybe an initial slowdown as people were really afraid about coming into the emergency department for anything because they didn't want to catch COVID. Other times there was things that were then peaking at other times. And we still need to go through and map out a little more. Our interviews occurred between October and April. October of last year and April of this year. So we also want to map out some of our interviews and are asking this question to what was the prevalence of COVID like at that time, at those different times, to see if there's a relation to that. One of the directors of emergency services said, "I feel like that's been our biggest challenge, and the fact that I don't know where the patients have gone. That's an oddity I can't really explain." So they noticed a real drop off in presentations of opioid overdose or opioid use disorder in their emergency room, and they didn't know why, and they couldn't explain where all those people were going. Someone from another hospital said, "I know that it has increased two things specifically, substance abuse and psychiatric issues. So I don't know if I could speak to it specifically being increased in opioid use, but substance abuse and in general overdoses. It's been a huge problem." Another thing that really complicated the referral process and the treatment process for people presenting in the ER, in the emergency department with opioid use disorder, was what to do with COVID positive patients. What were the protocols for all the different people that they were trying to coordinate with, the different organizations for treating COVID positive patients? And I have a quote here that speaks to that. "Because it became an issue of COVID positive patients essentially couldn't go anywhere, not even to our inpatient unit. I think it definitely slowed down the process, and maybe people missed out on opportunities because of COVID. And even if Epic wasn't affected by it, our perception that everywhere was affected may have caused us not to use Epic because we just assumed, what are they going to do because patients are positive?" It's that perception versus reality thing. When in reality, Epic probably maybe nothing changed for them, but in our minds, it changed for us because we got so many doors closed that at one point we were really struggling to send people anywhere. So one of the things that was observed was that there was a decrease in referrals during the pandemic to the intervention, and it wasn't clear, is this because of less people presenting? Is it because of other things that are going on in the referral process? And in many ways, our data suggests that it was a mixture of both. That that maybe at certain times there were fewer people presenting at the emergency department, and other times there was factors related to COVID that affected their ability to refer. So here there were assumptions about the availability of Epic that could have affected referrals to that program. And then just a general COVID focus during the pandemic. One of the emergency department physicians said, "Because of COVID, we just haven't been as connected to them or them to be able to come in and do stuff." And then people are just, like I said, hyper focused on COVID and distracted by that. So then you kind of forget about, oh yeah, we have this other program out there. The good thing though is that we do have a strong social work and case management resource that is in our department most of the day and evening. It's more in their forefront that, oh yeah, this is something that we can call for the patient, versus sometimes clinical staff forgets about those things and they're more focused on the clinical things, obviously. So it was interesting to hear about, the different roles that people are playing in the emergency department and how that will affect referrals to the program. And we're going to be looking at that even more in depth in some of the future analysis, as there were definitely different assumptions being made about process or about whether somebody was a good candidate for referral to the program. But these are just some of the highlights there that talk about how COVID had an actual impact on the program. Okay, I'm going to turn the time over to Danielle, and she's going to focus on some quantitative data.
Sounds good. Tracy, I think you need to stop sharing and then I'll pull up the slides. There we go at this point here. All right, so I'm going to provide a quantitative data analysis update that David Jamarlowitz and I have been working on. So for the quantitative data, we have a number of research questions related to the Casey EPIC program. Just some examples of those. Things that we're looking at are, what are the number and percentage of EPIC enrollees that remain in the program at key time points? Number and percentage of participants that complete the program, of those referred to EPIC, what percentage and how many engage in treatment or recovery services, the association between remaining in the program at key time points and ED and inpatient admissions for overdose. And we have many others. And these in particular, we plan on breaking out by different types of demographic characteristics, also referral sources, treatment sources, and those kinds of things. So recently, we've received de-identified client data from ComCare, and I wanted to thank Miranda Klink for providing us with those. She's met with us and spent a lot of time with David and I to figure out exactly what we need and the format that we need. And I know it's not easy to get data out of electronic health record systems. And I'm sure for those of you who've done it, you know the challenges of trying to pull data. So I really appreciate the work that she's done for us on that. So we've recently received data from April 1st, 2019 through July 8th, 2021. These are referral intake and continuing assessment forms from ComCare. We have 986 referrals. And these data are put in by the peer recovery coaches at different time points into their electronic health record. There's different screens, and Miranda was able to provide us with screenshots so that we would be able to look at exactly what the peer recovery coaches see when they put in the data. So that's really helpful in working on some of the analyses. So some of the challenges is when getting the data out of the system. It's in multiple spreadsheets, but there is a unique identifier for each client. All the data are de-identified, and so there's no information that would identify individuals. It's just a unique identifier that's used. And so David and I are in the process of merging these spreadsheets together based on the client identifiers. And we're also working on the data cleaning. So what I'm going to present are just some preliminary demographic characteristics for the referrals to ComCare, and they may differ a little bit from what you've seen others present because we haven't cleaned the data fully yet. So for example, for age, there's a few clients who've had ages entered that are well over 100 years old, which is probably a data entry error. So those sorts of things we're working on cleaning up. So this is just our preliminary, some descriptive analyses that we have. So in terms of who are the EPIC clients, little over half are male, a little bit less than half are female. There was one transgender individual who was referred to EPIC, and then less than 1% didn't have that field completed. So looking at the race and ethnicity of the clients in Casey EPIC, over 80% are white, 11% are African American, and then much smaller percentages for American Indian, Pacific Islander. Almost 5% identify as Hispanic. In terms of looking at the demographics, one thing that we're going to do is compare the demographics of clients referred to what you see nationally in terms of the opioid use disorder population, and also the population at Kansas City to do some comparisons to see what we would expect versus who's referred. In terms of age, the average is 41, although you can see the data skews younger with a lot of patients in the late 20s, early 30s range. As you would expect, this client population is mostly uninsured. And then there's fewer individuals with Medicaid, private insurance, Medicare, Medicaid in progress, and VA benefits. At intake, you can see a large percentage have been engaged in IV drug use. Fewer have been in treatment in the past year. And then a handful, a non-trivial number, have been pregnant. There were 34 individuals who are pregnant or have recently given birth, another 24 individuals. And so that's been an important population for the KC EPIC program to engage. This is clients reporting prior overdose and when. Many of the clients have had past overdoses and many recently, and that's probably not surprising considering that that these individuals are being referred from the emergency department, largely from opioid related visits. This is the referral source. So Truman Medical Center, Hospital Hill has been the largest referral source. And then you can see that it's not just hospitals. So Heartland, for example, Rediscover, Swope, and then recently EMS services have been engaged in referring clients as well. So in terms of overdose education received from the peer recovery coaches, large percentage receive overdose education. And receiving Narcan, not quite as many are receiving Narcan. Mostly no for other reason, with a few patients declining. So one important thing that ComCare collects in their EHR system is the additional needs that the client being referred has. So you'll see housing, transportation, communication, and childcare are some of the biggest ones. So the average time enrolled is 89 days. For those who become disenrolled, there's some who have completed the program. However, most become unreachable at the 30-day point, and then a much smaller number move, opt out, transfer, or are deceased due to drugs or other. Yeah, stop my sharing.
Great, thank you so much, Dr. Olds and Dr. Lapierre. That was really helpful to see the qualitative and quantitative findings to date. Next, we're going to hear from the Missouri Hospital Association. We'll be hearing their perspective on where we're at with opioid care since the summer of 2020, and you know, the Kansas City perspective. And so we'll be hearing from Sean Billings, who's the Vice President of Substance Use Programming with the Missouri Hospital Association. So the floor is yours, Sean.
Hopefully I did this right. You guys can see my slide deck.
Sure can.
That's it. All right, good deal. So good afternoon, everyone. Again, I'm Sean Billings. I serve at Missouri Hospital Association. So let's talk about substance use disorder a little bit. So it was July 9th, this time last year. The slide deck that I'm using this year is very similar, but there's been a lot of changes. So one thing that I'd like to address is Medicaid expansion. And obviously we know that that didn't necessarily turn out the way that we thought it was going to turn out. So it is currently in litigation. But if and when that passes, that's going to really open up a lot of needed services for roughly 274,000 Missourians. So what could a hospital do today? You know, I would say flagging those uninsured, underinsured community members that we serve, adults, staying in communication with them. So again, if and when this passes, we can help them either apply for or encourage them to apply for coverage. I mean, that's huge. So stay tuned to that, and hopefully things are going to work out for the benefit of, you know, folks in the state that need those additional services that right now they just can't afford to pay for. And Senate Bill 63, which addresses the prescription drug monitoring program. In case you weren't aware, before we passed this year, Missouri was the only state in the nation for the 9th year running that did not have a statewide legislated PDMP. So right now, St. Louis County is still driving Missouri's PDMP system, and they still have 93% of healthcare providers covered. But right now, through the Senate bill, they are forming an opioid task force to discern who that next vendor is, and then obviously working closely with St. Louis County Health Department just with that huge data migration. I have no idea how that's all going to take root, but the important thing is we're going to have an extra tool to both provide an additional safety net for the practitioner prescribing, as well as the community member receiving those prescriptions, just to make sure that there's no cross-reactivity and create additional harm. Third, diminished access to medication-assisted treatment. I mean, this is something that we constantly try to build infrastructure in to increase our prescribing power. So we have more docs that are willing and able to prescribe one of the three pharmacotherapies. The one that requires the Data 2000 waiver is specifically buprenorphine, one of the three medication-assisted treatments. Social determinants of health. I mean, this is just huge. It's not unique to rural or urban. Obviously, as we look at those different urban centers or more in the ag communities, it's different, but the hardships are still there. So we're constantly trying to address that. And as we just got some of the data on housing, childcare, even though we don't ingrain that in our other data system, we do have, our hands on the flex funds that pay and help subsidize those costs for the community members we serve. It's near and dear to our hearts. We completely understand that in order for me to get served through EPIC, to engage in treatment, to engage in pharmacotherapy, you have to take care of my housing needs, my transportation barriers, food insecurity. That's so critical. Stigma is another, just a big challenge facing the state that we try to address through our day-to-day work. COVID-19, I mean, that has impacted our program in every way that I can think of, but I'm going to punt that to Linda and let her address that. And then lastly, and I know this isn't news to anyone, but fentanyl is everywhere. It's all over our state, and so are stimulants. So it's no surprise to me that we've got and seen an increase in overdose deaths. It's, it's just everywhere. So what are some core strategies to address all of this? Obviously, at MHA, we do a lot of advocacy, and that's sort of our bread and butter. So we put a lot of efforts into Medicaid expansion. That's why we're in litigation right now, just to beat that war drum and try to open up access to more Missourians. We also had a strong footprint with the legislation with the prescription drug monitoring program. Again, we want to just create additional safety net for both the practitioner and the patient. The medication first model, it is a core underpinning of EPIC, and simply put, it is really cutting that red tape to get Missourians who need medication-assisted treatment, get them in the door quickly, right? You don't have to require that Sean Billings receives a 3-hour biopsychosocial in order for me to take that next step to see Dr. LaPierre to get my buprenorphine prescription, right? We understand that Sean is in withdrawal. I have intense cravings. We want to cut that red tape and expedite that therapeutic treatment that I can get. In this case, medication-assisted treatment. It's so important. And we have data that shows, the sooner that you can connect and link community members to this efficacious treatment, the better. And we're going to have better outcomes. Augmenting the ADA workforce, really utilizing peers, and not just within our program within EPIC, but really across the board. I can see peers, fast forwarding into the future a little bit, being in every single emergency department in the state of Missouri. Why? Because they're critical with that patient navigation, especially when they walk out of the four walls of the hospitals. Community members need that extra care, especially if they have use disorder, when they're trying to engage in a very complex system and all of these different services that they need. Again, understanding that I may not have a car, I may not have a home, I don't have an ID, and I have all of these other things that I need to take care of. It can be very cumbersome and very challenging for the coaches. Lastly, relationship building and stigma reduction initiatives. One example of that is a program connecting the dots that we work closely with in your neck of the woods. And it's nothing more than just really creating more opportunities for professional development across agencies to learn more about use disorder, what that means, how we can serve more thoughtfully in that space. So just a very high level status report for EPIC, and I will be very brief. So to date, we've served a little over 13,000. We've received a little over 13,000 referrals. You can pretty much cut that number directly in half as far as those that we were able to engage. So what happens to the half right out of the gate? They disengage, right? They give us poor information. We call the phone number, they never pick up. They give us an address that's bogus. So it's not due to lack of effort. It just really speaks to the complex needs that the community members that we serve have. And we try to do better. And that's why we have, folks like the QVIC to really take a deeper dive into our efforts to let us know where the gaps are. EPIC programming is offered in the Eastern, Central, Southwest, and Western regions of the state. There are efforts to do more in our rural pockets, but that's been challenging, especially with COVID. MHA-led EPIC programming, this is huge. I almost did cartwheels when I got the green light, and it's still taking root. But right now, as I speak, DMH, Department of Mental Health, and MHA, we're tweaking all of our business associate agreements, contracts, to expand our eligibility criteria beyond OUD to include alcohol and stimulants. And I think that's really going to be meaningful, especially in our Springfield Southwest corner and in our Western region. I've heard from EMS in both areas and from law enforcement and from hospital staff. Methamphetamine is everywhere. And we know that alcohol has been a problem for millennia. And then the intersection of COVID-19 and EPIC programming, what type of impact didn't it have? And that's it. So I'm going to stop share there if I can get my mouse to another screen. Do you have control of that?
All right, great. Thank you so much, Sean. And so next up, we're going to hear from ComCare. So we're going to hear an update on the Casey EPIC program from June 2020 through now. And so we're going to hear from Jonathan Bose, who's an EPIC program manager, as well as Linda, who is a peer recovery coach with the program. And it looks like we're well ahead of time too, so don't feel rushed. And also just a reminder to everyone to share any questions or comments you have in the chat.
Do all this here. There we go. Thank you. And yeah, I'll start off here, and then Linda will share some of her experiences over the last year. So, there's a lot of data already shown. I was going to share just slightly a little bit, maybe more. I don't know if it's just different. It's not any more data, but yeah. And I mean, I'll just say, like, through COVID, like a big, several of our struggles were all the things that have already been mentioned in terms of hospital. I won't say shutdowns. That's not the right word, but restrictions. That's been a challenge. Treatment facilities, housing resources, all of it, really put a pinch on, really vulnerable populations all across our city. And certainly the group of individuals that we serve around opioid use disorder, we're definitely part of that. So we do have really good, we just have really good partnerships in the city as well, though. So despite all the challenges individuals and partners were facing, we were able to do quite a bit still. And so over the past specific year, and I just finished doing some of this data, and I'm gonna double check my numbers super quick before I start saying anything too out loud here. Yeah, go. So just since, so basically July 1 last year to June 30 this year is what I was going to kind of cover. So we had 407 total referrals in the past 12 months for our EPIC program. About 120, try to get these right. Yeah, 129 were ineligible. That sounds like a really high number. Essentially what a lot of those ineligible numbers broke down into, though, 74 of them were ineligible because they just never called us back, or we were never able to connect to even complete an intake. It's a really high number. The previous year, it was about like half of that, not quite half of that. So again, COVID just really impacted our ability to even just go in and just meet with people, either because our coaches weren't able to, get into a hospital, or because they were grounded during the day and they didn't have, a lot of facilities weren't open. So, or at least not wanting extra bodies in the facility. So yeah, 74 just didn't complete intakes, and then about 55 of them didn't meet criteria for our services, and that's kind of a broad category as well. That could be everything from not having opioid use disorder specifically, or maybe they were out of the area. They actually lived on Kansas side or further outside of the Missouri or the Kansas City metro area, something like that. So I will say, after kind of running some of our numbers, though, we did provide 96% of our clients received overdose education. And so that's I think that's of all referrals, 96% of them did receive some sort of overdose education. And that's just been a really, it's a really important part of what we do, is just talking to people about how to stay safe, whether they're using or not. And so that goes a long way. And then 63% of our clients received Narcan from our coaches. And that is of eligible clients. So 63% of our eligible clients received Narcan from our coaches. And that's just, for them to carry, basically. And so that number we're working on to get higher, but that's where we were at for the last year. One thing we are proud of is about 63% of our eligible participants, 63% were also connected to MAT resources of some sort. So that's a really good number that we're really proud of, to say that, straight out of the gate, 63% were connected to MAT. Now there's plenty to have conversation around, like the longevity of that, and all of that. But just to be getting people connected is a huge success that, again, our coaches deserve a lot of the credit there. Just being out in the community, driving people around, connecting people, whether it's getting them Uber rides or taxi rides or making sure they get to treatment centers one way or the other is really important. So those are kind of the 4 big numbers we look at, right? Referrals, connection to MAT, overdose education, and Narcan distribution. And so those are four big ones I wanted to share about for the past year. So with that, I was gonna have Linda share. She's our been one of our coaches here since the beginning. And so Linda, I'll just let you take off, share with us a little bit about your experience. What's it look like to be a coach? What are some barriers that you face, that the community faces, et cetera? And then go from there.
Okay. So hello to everyone. And the first thing I want to address is the Narcan number. Our Narcan numbers are down because of COVID, basically, I feel like anyway. And we're not allowed to distribute Narcan to a client in the emergency room. So when we go meet a client who is in the emergency room because of legislation, or I'm not sure. Anyway, we're not allowed to distribute Narcan to them. So the Narcan has to be distributed after or when we meet them face to face off of the hospital property. So that's one of the reasons. I know somebody had asked a question in the chat as to why people were declining Narcan. I've had a few people decline Narcan, and I usually can talk them into taking it, even if they just want to give it to a friend. So, but anyway, a day in the life of a coach. Basically, we get our referrals from anywhere and everywhere. We used to just do hospital referrals and respond to the emergency room, meet with the client, help them get connected to whatever services that they're interested in. The first thing I usually do with a client is to let them know that I myself am in recovery. That's a huge icebreaker. And the second thing I do is ask them, what do you plan to do when you leave the hospital? What are your plans when you're done here? Sometimes they have a specific goal in mind, and sometimes they say something like, I don't know, I just want to quit using. So then we talk about what are the options you have to quit using. My main goal, if the client is agreeable to it, is to get them on medication. And we do have an agency in town that we can get medication within 24 to 48 hours to the client, and they will provide them with a bridge prescription as well. We have a handful of doctors at some of the hospitals that will dose a client while they're in the ED. And then we have a shorter number of doctors that will actually write them a bridge prescription. That is a blessing when we are able to have that doctor do that. But unfortunately, a lot of them are not able to or not comfortable doing so. So then as an EPIC coach, I get the client to the agency to get their Suboxone. And then we get them connected depending upon where they live or where they stay the majority of the time, because a lot of our clients are homeless. So whatever area they reside in, the majority of the time, we try to connect them with the agency that is closest to them for follow-up services. Sometimes that means just continuing their Suboxone. Sometimes that means they do outpatient. Sometimes they do inpatient. If we have a client that is homeless or does not have a safe place to live, we get them into sober living. EPIC is blessed that we have flex funds. So we're able to pay a week's rent for them at sober living and buy them a week's worth of groceries. Sober living kind of takes over from there and helps them with employment. And most of the clients that I've worked with that I've gotten into sober living have had a job within that first week and started working and really feeling better about themselves. So our sober living houses around the area are a huge blessing. And the fact that we're able to help, that EPIC as a whole is able to help them out with a week's rent and some groceries is also a blessing. During COVID, there were a lot of changes that transpired. It was basically, for me as a coach, it was basically a matter of just pivoting to doing everything remotely. It did put a hamper on us, but fortunately, the one place that we could get Suboxone within 24 to 48 hours remained open during the entire COVID. It was a little bit trickier to get clients in, but we made it work. I do believe that face-to-face is the best, but if you spend enough time on the phone with someone and you talk to them human to human and person to person, you can establish a rapport with them. And if you let them know that you're there for them and you really want to help them, I've had good luck with people continuing with our services, even though I've made a phone call to them rather than going in person. But having said that, I still think that in person is the best. So we do follow up with clients for up to a year. Sometimes I have a girl on my caseload right now that I've had for a year and a half because she just keeps struggling and she still needs our support. So we do keep clients past the year. It's not get to that year mark and kick them to the curb. If we feel like they still need help or they act like they want to continue with services, then we do. We just don't collect data on them past that year. And as far as successes, I do have one success story that I'd like to share with you guys, although I have many, but this one is kind of beginning to end. I had a client that I got, I think she was one of my very first clients. And I went to pick her up here in my hometown in Excelsior Springs. And she got in my car, and I really honestly do not judge people, but I'm a human being, okay? And in the back of my mind, I'm thinking to myself, this girl is not gonna make it. She's just not gonna make it. She was in really bad shape. She was in horrible withdrawals. Anyway, I got her over to the agency to get her started on Suboxone. In speaking with the nurse there, we discovered that she had heroin in her bra. So we got rid of that, and she got started on Suboxone. She got her first dose of Suboxone that afternoon, and the change in her just from when I had picked her up to getting her first dose of Suboxone was amazing. She went on to go into inpatient the following day. She already had that set up. She went to inpatient the following day. She followed through with outpatient after that. She went to sober living when she got out of inpatient and continued with her outpatient as well as her Suboxone. She eventually went to the Hillcrest program. I did forget to mention that when I first met her, she had lost custody of her children. They were in custody of her aunt and being supervised by DFS. So anyway, we progressed a few months and she got into Hillcrest living. She got full custody of her children back. DFS is no longer in her life. And she went on for another year, and she is now a brand new coach with the Epic team in Kansas City. So that is a story that has come full circle. And yeah, not all of them end up that way, unfortunately, but we do have a lot of successes. And I consider if I can get somebody started on Suboxone, even if they drop off, and this happens very frequently, we get them that first bridge prescription of Suboxone and they take it for a week and they're feeling so good that they think they've got it whipped and they just go on about their business. And then about day 2 or 3, they're like, oh, this isn't going to work. And a lot of times they'll reach back out to us. I've had several clients who have fallen off the map. I have no idea where they went. I can't get a hold of them. Phones are disconnected. They don't live where they used to live, whatever the case might be. And out of the clear blue sky, I'll get a text message from them. They'll message me on Facebook. They'll call me, however they, prefer to reach out and ask for help. And of course, we jump right in and get them back on Suboxone or whatever their choice is of what they want to do. So it's a great job. I will say that. I enjoy it.
We love you, Linda. Maybe I'm making this up, but is this the region where you guys recently either hired or offered a position to one of our community members that has successfully gone through Epic? Or am I
Yes.
thinking of a different, okay. I mean, to
That's the
me,
story.
that,
That's the story I just had.
yeah, okay, yeah. All right, just making sure. Because there was one in the eastern region where that occurred. There's one in the southwest region that, I mean, to me, that's like, right? That's what this is about. I mean, yeah, my hair is just like standing up. I mean, every time, yeah, it's just, that's good stuff. Good stuff.
So if anybody has any questions, I'm happy to answer them. I'm pretty much an open book.
This is so great. These have been such good perspectives and so wonderful to hear from everyone. We have about 23 minutes remaining, so we have plenty of time for a good discussion. I'll kind of turn it over to our project leads. I think maybe Tracy and Holly are kind of leading the Q&A session. And so I'll let you just kind of kick things off. If anyone would like to unmute themselves, we can make this definitely very discussion oriented, and you're more than welcome to unmute yourself and ask any questions or make any comments that you have.
We're perusing the chat too, but I do think almost everything was answered in the chat by other people, chiming in. And Sean posted the statewide reports for information. I don't think we missed anything in the chat, but one thing I'd like people just to comment on the reflection of the expansion, some of the things that Sean mentioned, the changes that are coming around expanding the stimulants and alcohol, which is wonderful news. We did see that in our preliminary analysis of the data about, that just the focus on opioids because of the federal funding, could be a barrier to reaching more people. So what are people's thoughts on that, especially people running the program like Linda and Jonathan and others?
Well, my thoughts are just excitement that we'll be able to serve more people. We actually are doing a pilot project through a separate grant where we are accepting referrals for people who use stimulants or alcohol. And it was initially EMS based and we were getting some referrals there, but then when we opened it up to some of our hospital partners, the referrals really just kept flooding in. And it's like, wow, there's so many more folks out there who could benefit from our services, from the amazing work that Linda and the other coaches do. So I'm really excited.
Thanks, Miranda.
Yes, I'm very excited about it too. It's been sad as a coach to get that call, particularly on self-referrals, because for me, and not that the other referrals are not necessary or not good, but for me, it's been when somebody calls in themselves, it's a huge deal. And when I get a call and I find out that, the only thing that they use is meth and all I can do is give them some phone numbers and addresses, I can't help them the way that Epic is able to help them. So that's sad. On the flip side of the coin, I hope this means we're going to be hiring more coaches because I can see this whole thing exploding and yes, and being a little overwhelming. So because it's huge enough with just opioids. So
I'm gonna just jump in here real quick. I'm gonna share that slide that was talking about overdose deaths by drugs again. In the qualitative interviews, it did come up quite a bit, like in terms of like, what's your wish list or what could be done? And a lot of the staff was saying, we really wish that we could do something for people that have problems with stimulants. And if you could see my slide here, this is the 12-month ending provisional number of drug overdose deaths by drug in Missouri. And this gray line here is the psychostimulants with abuse potential. And so you could see that is something else along with the opioids that has been increasing in Missouri. And it did come through in a lot of our in a lot of the qualitative interviews. I think that there's a lot of supports out there for alcohol abuse, and a number that they talked about, like Alcoholics Anonymous and things like that. But the psychostimulants for potential for abuse was definitely something that's come up quite a bit, and you could see it's represented in the quantitative data as well, that's becoming an increasing problem as well.
Yeah, and just to highlight that a little bit more and answer about the MAT is like, you know, some of these barriers are extra, I shouldn't say barriers, but it is a barrier for people to prescribe medication for addiction treatment. Some of those have been removed for doctors, but I don't believe we saw like a mad rush of doctors finally breathing a sigh of relief. You know, the ones who didn't prescribe MAT before still don't prescribe MAT. That 8 hours training, while it was a barrier, it seems to me was almost kind of an excuse not to have to do it. And now that barrier's removed, and they're still like, yeah, I'm not comfortable doing it, right? So it's not like now they can and they do. That's still a challenge. We've seen a few more doctors, I think, in the EDs give us bridge prescriptions or give a dose since some of those restrictions have been removed. But you know, there's still a lot of education and destigmatizing around medication for addiction treatment that's really necessary. And one of the great things our coaches do, they share stories like Linda did today. Like, hey, we've seen patients like this before, and after a dose or two or a week's worth of dose or whatever, they're different people. And it is absolutely true. So that's a really great thing. In terms of other drugs, you know, I think in Kansas City, we've seen some ebbs and flows over the last couple months where, and I bet I closed all my data out now, but where we were at about maybe like 20 or 30 referrals a month for a while. And then all of a sudden we had 50 in a month, right? They just flooded us. And even this last week, you know, we've had 3 or 4 referrals a day for like a week now, which is, again, it doesn't sound like a ton, but for Kansas City, that's quite a bit of what we've experienced in the past, where we'd have maybe 3 or 4 a week. Now we're getting 3 or 4 a day, and pretty quickly. Like, it wasn't like it titrated up. It went from like 3 or 4 a week, and then the next week we had 15 referrals, you know. So it's been really interesting to see some of those ebbs and flows. And as we kind of expand our communication with different groups, it often like ebbs and flows with like law enforcement drug, you know, they catch onto a drug bust, or the hospital see an uptick, or EMS sees an uptick in EMS calls for overdose. You know, Epic, we're just seeing those same trends, and we haven't been able to marry them together yet and, you know, figure it all out, but that's where we're at as well. So the addition of some additional program funding that has allowed us to outreach, you know, stimulant use disorder and alcohol use disorder, has just reconfirmed what most of us already know, and that's that people don't just use one drug. And that's the main thing, is they're using methamphetamines, but a lot of those methamphetamines are being mixed with fentanyl or other opioids, which is leading to an increase in overdose deaths for individuals who thought they were just using stimulants. So it's a lot. And as Linda said, those referrals can come fast and furious sometimes, and it's really hard to find a connection point at times. So there's still lots of work to do, and more partnerships are better, obviously.
Mhm. Well, thank you all for those reflections and acknowledging some of the barriers that we really need to remove rather quickly. You know, the CDC, obviously, Tracy shared the Missouri data, but we just reconfirmed what we feared over COVID, which is that the overdose rates across the country, you know, increased more than ever, and deaths due to overdose. So we do have a question from the chat, which is a good question.
We lost her.
Oh, we sure did. So yeah, the question in the chat was about what's holding docs back or other providers from providing that bridge prescription? I think, yeah, there's, what are kind of the reasons for the hesitancy?
I can jump in, and then Linda, Jonathan, whoever. In my conversations with physicians, oftentimes what I hear is they understand that buprenorphine has street value, which it does, right? And then if I don't have a coach like Linda that's going to physically meet me up at the hospital for that warm handoff and help me fill that script, I just don't have the confidence that that's what's happening, right? So again, I think that's one of the beautiful things about Epic is it doesn't matter what time of day. If it's 2 a.m., we're going to be by your side, and we're going to help other practitioners in support of that community member, understanding it is a team and it's required. The old adage, it takes a village, and that is specifically a caveat within that training and the certification, right? They have to have some sort of mechanism post-script for basically community engagement. Well, we're built in. You already have that with Epic. So, it's just plug and play. But that's what I hear a lot. It's just that concern, right? And then another thing, just more broadly, I hear often is look, Sean, it's not that I don't want to serve in this space, but I don't want to get this BUP waiver and then that be my practice. I'm not board certified in addiction medicine. I don't want to do this all day, every day. And that's a fear. And yeah, that's a theme.
Yep, I think I would just second that. Is a concern that the Suboxone's our primary medication of choice. That's what a majority of our community members are receiving from our community partners, and it's exactly that. Is that we don't want them to abuse that prescription, sell it on the street or whatever. So that's there's plenty of research. I shouldn't say plenty, but there is some research out there that says that's not really true. People aren't like diverting Suboxone for nefarious purposes. They are, if Suboxone is diverted to other uses other than to the prescribed person, it's often so another person can not be sick. So it's used for the correct medical reason on the person who's not prescribed it, right? But it's used for the reason that it exists. So that's good news. In my mind, it's helping other people. But then what'll happen? I think we had a patient recently. It was a husband-wife team coming back. The wife was coming back, and she was sharing her Suboxone with her husband. The husband wasn't enrolled in our program. He wasn't enrolled with the doctor. She was sharing the Suboxone with her husband because he had the same issue she had. So of course she ran out, twice as fast as she should have. So, we see that a lot. People sharing with their friends and family because they don't know that they can get help. So the community members sometimes don't know how to ask. They're worried about asking for too many people, right? What Sean just said, doctors are maybe hesitant because they don't want to become the doctor that everybody comes to the hospital to ask for. And then, there's still a large stigma, both in the hospital world, but even in the recovery world, that it's just a drug for a drug. We're just trading one addiction for another. Call it what you want, but it's still a drug. And we have, unfortunately, that's still just a belief that exists out there of saying that's not, it's, I don't know how else to explain that. Somebody else can try to get my words out of my mouth. But people still have that stigma that Suboxone is just trading a drug for a drug and it doesn't actually help people. Just blatantly not true, but that's still the belief.
I think that that something that came through in our interviews as well, that idea that, even if people can be trained in it and some of those barriers have been reduced. I recall this idea being expressed that as a emergency department physician, they're saying their role is to treat their acute condition in the moment. They're not there for like continuing a long-term treatment, and they really saw that the medication-assisted therapy was something that has to be tied to some long-term kind of follow-up with a treatment center with support in the community and things like that, and that they don't want to just hand this over to somebody without all those supports being in place, and that so they didn't see that as being their role to do that. So that did come through
That's
in
great
some
feedback.
of our interviews as well.
You know, one thing, just to feed off of Holly's comment, just to share, not to digress too much from what we're talking about, but North Kansas City Hospital right now is knee deep in their community health needs assessment. And we were working with the MORE project to hand them naloxone for distribution straight from their ED, us giving that to them. And they're doing that. And they've got a beautiful brochure. So effective, I think, July 21st, whether it's Sean Billings, I'm opioid naive. I just got an injury, never been, hurt before, to Sean Billings, a full-blown opioid use disorder. I will receive that education and I will receive that kit. And I mean, that is how, in my small opinion, that should be done and seated within our hospitals, right? And the coaches should subsidize them when they forget or they're too busy, just because they have the audience. And what happens all too often is Sean Billings leaves the ED, Linda can't find me, and it's a missed opportunity. And the ED staff didn't provide me with that Narcan kit. So to me, that we just need more North Kansas City hospitals. And it's nothing less about our other hospital members. We love them to death. It's just something more about North Kansas City. They want to serve more thoughtfully in that space. And that's what it's going to take just to save more lives, simply put.
Thank you, Sean. I'm sorry, I got Murphy's Law. Of course, the internet went out on me. I do want to maybe add to the discussion about the overdose prevention component too, because that is very important. And I do appreciate that Jonathan brought those numbers into our discussion, that you have provided not just the Narcan and distribution, but also the overdose prevention information. From a federal perspective, this current administration, and I've been in the field 20 years, I'll age myself, I'm 50 this year. But in the last 20 years, we have really never been able to have federal policies that very routinely discussed harm reduction interventions. And part of the Biden and Harris administration's priorities is harm reduction. So we are at a very key point in being able to really delve into evidence-based practices around those interventions and the workforce that supports them. So what are your thoughts on these new components?
Is that to the broader group or is that directly to me?
Anyone who wants to chime in and be passionate about overdose prevention. Love harm reduction in public health. Kate, do you want to comment on it more?
I will say, in terms of harm reduction, overdose education, I mean, there's layers to it, right? There's different levels, and I mean, gosh, you want to go in deep, just Google a harm reduction website or something like that. And harm reduction websites, they go, we're talking harm reduction goes, safe using site, right? Safe injection sites, clean needle exchanges. And all those things are really taboo. I mean, Midwest especially, but even all over the country. I mean, you hear things in Philadelphia and even California, San Francisco. Those things get a lot of pushback from the community. So if we're talking true harm reduction, we're just scratching the surface. I mean, literally our overdose education, which is our primary, and Narcan distribution, which is our primary avenue to harm reduction in Kansas City right now and through EPIC. I mean, that's the bare minimum. It can go a lot deeper. We just don't, I mean, the infrastructure there isn't built out in Kansas City at all, but it is important. And, people, one of the things we started doing as well is handing out fentanyl testing strips, and a lot of clients are still kind of declining those. And Linda, I don't know if you've had that experience and you want to share about that, but we have them, right? We got 500 of them. That's not a lot considering we get, one testing strip per person is not going to help a lot. So we might hand out 5 or 10 per person. But even our clients are declining some of those. But fentanyl, it just being in so many different drugs now. I mean, even marijuana is getting laced with this stuff. In Kansas City, I kind of had a naive belief that fentanyl would take a few years to get to Kansas City, and it's hit us really hard. So, we are doing our best to reduce harm by sharing with people, safe using practices, how to avoid overdose, providing fentanyl testing strips, because you just never really know. But Linda, I know you'd mentioned it even just the other day that some people just outright decline the fentanyl testing strips. And do they give you reasons why, Linda?
Basically, I think that the reason that Narcan and fentanyl get declined when they do get declined is the client is at a point in their heads anyway. I'm not going to do this again. I'm not going to go back to using, so I don't need fentanyl strips and I don't need Narcan, which is why I usually try to convince the client, not necessarily to take it for them, but I'll say something like, okay, well, you're not going to need this anymore. You're right. But I'm sure you have friends who are still using, and this could help save their life.
Yeah.
And then they'll take it from me. And I don't do that with the fentanyl strips because they're quite expensive and I don't know where they're going to end up. They could end up in somebody's trash can, not used. But yeah, and as far as the overdose education and harm reduction, I kind of base my overdose education. I do that towards the last of my conversation with the client, because after that, I've learned something about the client. I know whether that person is ready to, is wanting to stop using, or I've had clients that'll tell me, well, I'm not ready to stop completely. So if that's the case, then I share the, don't use alone, make sure you have Narcan there. I share how to clean needles appropriately, don't share needles, don't reuse, that kind of thing. I don't go into that with somebody who's laying there in the hospital bed going, I don't ever want to use again. So then I give them the overdose education in that, well, that, or, I hope you know that if you get to a point where you're tempted to use, the dose that you used to use and you don't know if it has fentanyl in it, could be your last dose. And we talk about that. So it kind of is geared on what information I've gotten from the client, but I'm all about harm reduction. I wish we had needle exchanges and safe injection spots and the whole thing. I think it would drastically decrease our overdoses, but just me thinking.
Well, I know we only have a few minutes, but Linda, I appreciate it. And there is one more comment in the chat that we can get to about if the infrastructure is there. I think we all agree that there's many barriers in all of these processes. And if we were as a society ready to adopt some of these other harm reduction strategies, we'd have to address those barriers in our systems and access. But Linda, what I heard her saying was, you're meeting people where they are and where they are is where they need to be at that moment. And that's what makes you a great recovery coach. So I know I'll hand it over to Stacy. We are close to the end of time. I want to respect everyone's time, but I'm just grateful to be on this research team, and I'll turn it over to Stacy.
Oh, and we're so grateful for everyone in this call today, both attending and also all of the presenters and everyone participating with KC Epic. It's really, and all the other Epic programs as well. It's really great. So that's all. I want to give everyone, I guess, a minute back, but do, thank you to everyone, and please do join us. August 19th will be our next KC QBIC forum, and that one will be on healthcare delivery in a post-COVID world, and we do have some exciting speakers that we're finalizing now. So thank you so much, and everyone have a great day.